Well, we should get started. Welcome, everyone, to Cardiology Grand Rounds today. My name is Jim Kirkpatrick, and I have the distinct pleasure of introducing our Grand Round speaker today. Karen Ordovas did her residency at the Instituto de Cardiológica do Rio Grande do Sul in Brazil and at the Hospital May de Deus in Brazil. But she comes to us most recently from the University of California at San Francisco, where she did her training in cardiothoracic imaging and then rose through the ranks to become the professor in residence. Fortunately, we were able to lure her away just this last August to become the section chief of cardiothoracic imaging here at the University of Washington. Now, Dr. Ordovas has had a truly stellar career. She has over 130 publications. She has a long list of grant-supported projects. She has lectured literally all over the world, from China to her native Brazil. She is an associate editor for Circ Cardiovascular Imaging, and among many other honors and distinctions, she is the past president of the North American Society of Cardiovascular Imaging. But I also want to highlight the fact that a full 2 pages of her CV is dedicated to a list of the mentees that she has guided through their academic careers. It is truly impressive. And perhaps most importantly, in this day and age, she has contributed significantly to many, many careers of people who are traditionally underrepresented in the medical profession. She has been a true advocate in national society and the local level for women in medicine, and she has been a true advocate also for patients, particularly women, in cardiovascular imaging. And it is a truly wonderful thing that we were able to bring her to the University of Washington to collaborate in cardiovascular imaging here. And I want to give her special kudos for moving her entire family during a pandemic. That may be one of her most impressive achievements. Without further ado, Karen, thanks so much for giving Grand Rounds today.
Thanks so much, Jim, for such kind introduction. It's really an honor to be here and join UW. And I've been people in the department have been so receptive in cardiology here. So I'm looking forward to many years of collaborations here. So without further ado, I was asked to share a little bit about myself and where I come from. So this is South America, as you know, and the state I come from is that little orange one all the way south, which is called Rio Grande do Sul, very well pronounced by Jim in his introduction. So it's actually cold. It snows sometimes, and there is wineries in there, and it's where the gaucho come from. So we eat tons of steak, not very good for cardiovascular disease. So I came from Rio Grande do Sul to San Francisco, and I did that in 2003. And I came because I really wanted to learn about this thing called cardiovascular MRI. So I wrote a letter to Charles Higgins, which he was one of the inventors of the method, and he very happily took my application, and I came for a postdoctoral fellow. And then when I got there, how surprising that I met one of my main career mentors there, Dr. Gautam Reddy, who most of you know, who have been a mentor for many years. So that duo actually convinced me to stay 3 more years as a postdoctoral scholar. And then I joined a clinical fellowship. I did a master in clinical research. And finally, I joined the faculty in 2007. I joined as full professor in 2018, and I had a very happy 13 years at UCSF. So this is from UCSF website. Now, this is real life. This is how my life was going through in California. So I came as a postdoc. During fellowship, I had my first baby. During masters, I adventured in the second one. And we have Antonio and I have this wonderful family that were brought up in California and now brought to Seattle. So this is us now during homeschooling. That's my 7th grader during his PE shift. and my fifth grader doing biology classes. That's us in our convertible, still hoping to have sunshine, moving to Seattle during the pandemic. So that's a little bit of myself. So let me just show you a few slides on the collaborations I had at UCSF. So one of my most exciting jobs there was to co-direct the multimodality imaging fellowship with cardiology. And these are our 6 stellar level 2 certified cardiac CT and MR fellows that are now all in the field of multimodality imaging, and I'm very proud of them. In radiology, I had multiple mentees that did research and clinical work, and that's something I'm really proud of and willing to start these collaborations here. These are my main collaborators in cardiology. So I've had several papers and grants with electrophysiology team, the adult congenital heart disease, preventive cardiology, heart failure, and hypertrophic cardiomyopathy. And some of these talented women cardiologists were my mentors, like Elise Foster and Teresa DeMarco. So I have a lot of connection with the cardiology team there, and I'm hoping to build here. So I had the honor of, as Jim said, being the president of NASCI last year, and then I was able to give the gold medal award to Dr. Higgins and thank him for all he did for me. And next, well, I'm not being able to move the slide, there we go. And now I'm just joined the board of directors of the Society of Cardiovascular MR. I'm gonna be the president in 4 years. And a lot of that recognition was for founding and working with the Women in CMR group, which is a dedicated group for defining and promoting the role of cardiac MRI for female cardiovascular diseases. All right, that was a lot about myself. I don't usually talk about myself. So let's start talking about the scientific topic today. So we're gonna talk about advanced cardiac MR methods to look at regional myocardial strain. We're gonna first talk about ways of quantifying myocardial strain. We're gonna give a few examples of how myocardial strain can be seen in cardiomyopathy. And finally, I'm going to show you a few examples of how we can build patient-specific models based on strain and help predict risk and simulate interventions in multiple diseases. So let me just move the camera here because it's right on top of my slide. See if I can put on the, okay, there, much better. So, since the beginning of medicine, really delineating the geometry and the anatomy and the function of the heart has been one of the center interests of our profession. And today, with advanced engineering and imaging methods, we can really go deep and create what I like to call heart avatars for simulation of cardiovascular treatments and interventions. So let's start talking about quantification of myocardial strain with MRI. So what is myocardial strain? So it's a measure of relative lengthening or shortening of the myocardium or myocardial fibers. And it actually measures changes in distance between 2 points per cardiac beat. It's an estimation of the deformation of the myocardial fibers, and it's a parameter of cardiac function that can be altered far before we see decrease in ejection fraction. So this slide shows how complex the geometry of myocardial fibers are. I have here in a histologic cut into short axis plane, the multiple different orientations of the subendocardial, mid-wall, and subepicardial fibers. And I love to show this diffusion tensor imaging model showing how complex the orientation of the fibers are, in this case, in the left ventricle. So it's very challenging to measure strain or deformation along the precise alignment of the myocardial fibers. And that's why we need to decode that into multiple components. And we do that by measuring the radial strain, the circumferential strain, and the longitudinal strain in the same fashion that is done with echocardiography. So the radial strain is measured in the epicardial to endocardial plane. The circumferential plane is measured along the circumference of the left ventricle, and the longitudinal in the apex to base direction. In addition to that, we can also measure torsion of the heart with strain images. So rotation is the name of the parameter, and it basically measures how much the rotation of the apex performed relative to the base of the heart. It's measured in degrees, and it really measures that torsion or like towel twisting action of the heart for the pumping function. In addition to those 4 parameters, we can also measure some diastolic parameters like diastolic strain rate and other parameters that I'm not going to focus on today. So let's talk about tools that MRI can offer to measure that deformation. So the first one is what we call steady state free precession. For those of you that are familiar with MRI, this is the nickname for this technique is white blood or cine images. And these are the bread and butter technique that is used for MRI and can measure wall thickening and can be used for assessment of strain based on feature tracking techniques. Then in addition to that, there are more advanced techniques. We're going to discuss today SPAM or tagging, displacement encoding with simulated echoes, and strain encoded magnetic resonance. I don't want you guys to become experts on these techniques. I want to show you what's the advantage and disadvantage of them and how we can use them for research and clinical practice. And finally, I'll show you the final product of combining all the strain methods and geometry of the heart into computational 3D model. So let's start talking about steady state free precession, or the most basic way of measuring regional cardiac function with MRI. So here I'm showing to you one acquisition in the short axis plane all the way from apex to base. This is performing about 3 breath holds. And down here, acquisition in the 4-chamber plane, 2-chamber plane, and 3-chamber plane. To get a full stack of cardiac functions, such as this one, usually 5 breath holds are needed. So it's a really easy set to obtain, and it can give you regional function of all the different myocardial regions based on the AHA segmentation. So this is the most basic. We would measure outline the endocardium, the epicardium, and measure how much the myocardium thickens during the cardiac cycle. That's used in clinical practice every day. A twist to it is to display the information of radial thickening in this time to peak fashion. And here I can show you the synchrony map obtained with MRI, in which you can see different segments peaking at different time points in a patient with the synchrony. And here a patient with synchronous cardiac contraction with the peak basically aligning for all segments. So most basic way. Now, if you want to go more advanced than that, this is work from Dr. Liu at UCSF, in which with free breathing 3-minute acquisition, it's actually possible to acquire a full 3D cine of the heart and then use our feature tracking and analysis of regional dysfunction, taking into account the through plane displacement, as opposed to just looking at multiple 2-dimensional slices. In addition to that, we've been looking into separating this 3D function into inspiration and expiration. So to what we like to call the 5D cine images, showing the effect of respiration into the regional function. Now, what about feature tracking? So for cardiac MR, it's a relatively new technique. It started about 2014. And it's very similar to speckle tracking echocardiography. So basically, the software looks at subtle signal variations within the myocardium and tracks those. There's no need for special acquisition. So let's say you had a patient that 10 years ago got a cardiac MRI for a particular indication. We could go today, apply speckle tracking or feature tracking, and measure strain retrospectively. It's a very fast post-processing method, And there's a few software nowadays that are commercially available, including Circle and TomTac. So this is an example of a feature tracking post-processing of a cine MRI. So here in a short axis plane, you can see that I outline in red the endocardium and in green the epicardium. And the software detects those areas of subtle signal variations and measure that along the cardiac cycle to measure strain. You can then depict that in 3 dimensions based on multiple 2-dimensional acquisitions in the short axis. And here's an example of how a right ventricular strain map can also be obtained with strain speckle tracking, or feature tracking, I should say. And then the output of the software is very similar to what we see with other strain methods. We just have this bull-eyes graphic for radial, circumferential, and longitudinal strain. So this method has been validated against what's considered the gold standard for MRI, which is the tagging technique, and shows very good agreement and correlation with the gold standard. So what is the tagging MRI, which people call the gold standard? So this is called SPAM, or spatial modulation of magnetization. So it's a very interesting concept. So what happens is that end diastole, you basically do a saturation band. You produce this black line in end diastole, and then you follow the deformation of that line along the cardiac cycle. And you do that in 2 perpendicular directions in the 2-dimensional plane. You just follow the deformation of the stags. Now, this is a completely 2-dimensional method, and the spatial resolution is limited to the distance between the 2 lines that you produce. So this is an example of a full examination with MR tags. Here we have base of the heart, mid-ventricular level and apex, at end diastole and end systole. And what the software is going to measure is how much these little squares deform during the cardiac cycle. Here's an example of a cine loop showing those little squares and the deformation. And you can notice that lines of saturation kind of fade over the cardiac cycle. At the end of the acquisition, you barely see the lines. So this is an example of a study we did in patients with tetralogy of Fallot, showing a circumferential strain in patients and healthy volunteers. And you can see how the negative circumferential strain is decreased in patients with tetralogy of Fallot compared to volunteers. Same study, we also looked at the rotation, and we can see that in patients, the rotation was lower and delayed compared to rotations in healthy volunteers. So this is all based on tagging MRI. So the advantages is he's been around forever, since 1989. There are extensive validation studies with phantoms and extensive data in animal and clinical research. But the disadvantage of this method is that tagging lines fade over time and may not be clearly detected at the end of the cycle. It's very time consuming to do the post-processing. This was one of my postdoc projects, and I would take 2 hours to outline one single case. And it has a low spatial resolution, limited between the space between 2 lines. Now, this is more advanced strain imaging with cardiac MRI. This sequence is called DANCE, or displacement encoding stimulated echoes. And it's specific to one particular MRI vendor that we do have here at UW. It uses the phase of the voxel, which allows for high spatial resolution of the displacement. So basically what it looks, it's for every single voxel, it's going to track how much it moves along the cardiac cycles. And it also takes into account the true plane motion. Although it looks like a 2-dimensional acquisition, when that plane moves in and out of the acquisition plane, it takes into account that particular motion. It's a very quick post-processing analysis, and there's no issues with fading of the lines at end diastole. I see someone raising a hand and asking a question, but I can't really see the question, Jim.
Why don't we take that at the end? Okay. We'll let you continue, and then we'll go back to that.
Okay, so this technique was developed at the University of Virginia by Dr. Abston. And this is how the post-processing tool looks like. So this is a short axis cine. Each tiny little yellow dot is a pixel or a voxel. And you can see the displacement during the cardiac cycle tracked by this particular technique. We did a small study just looking at 5 normal volunteers and looking specifically in our scanner how dance and tagging correlated, and we found a very good correlation. And indeed, dance perform a little bit better, which is when we have problems with the so-called gold standard of any particular technique. Now, finally, the last technique I want to show you is called SENC, or strain encoded imaging. This is basically an evolution of that basic tagging sequence. And instead of building the tags in the in-plane acquisition, you build it through plane. So we don't actually see the lines, but the software is able to follow the displacement of the lines. The output looks like that. It's both color-coded and quantitative, and it shows you in different color maps the areas of maximum strain. It's a very easy post-processing, but it's only one company that has the sequence to acquire and the software to post-process. So it's kind of an interesting feature of the sequence. Okay, I'm done showing you all the tools we have with MRI to measure strain. Now, let's just review a little bit of applications of strain measured by MRI in cardiomyopathy. So really the most important potential applications are for early detection of LV dysfunction before the ejection fraction drops. And the potential roles are for risk assessment and to allow for early intervention in an effort to preserve function. We can also build patient-specific models and simulate different environments for the heart to predict remodeling and simulate interventions. So those are the most interesting applications of the method. I'm going to start showing you this classic data from the MESA trial that looked at strain to predict development of heart failure. So as you all know, MESA trial is a cohort of healthy asymptomatic patients aged 45 to 84. And after 4 years of follow-up, they looked at cumulative hazard for incident heart failure. So these are normal patients that ended up developing heart failure. And we can see that both global and mid-wall circumferential strain were very good predictors of development of heart failure in 5 years. Another application of strain MRI is in the field of guiding resynchronization therapy. So this slide basically summarizes the concept. You can see in A and B, the acquisition of this regional strain. Then you can see a color-coded 3D map showing, or the yellow arrow is the area where there's the latest peak contraction. So a very 3D desynchronous map. And the concept is that you would do your resynchronization, putting the lead matching the site of late contraction. So Dr. Abston, who developed the dance sequence, ran this study. They look at 75 patients with heart failure, either ischemic or not, and follow them for 2.5 years approximately. And they use this parameter called CURE, circumferential uniformity ratio estimate. Basically, if the parameter is close to 0, the contraction is very desynchronous, where if it's close to 1, it's very synchronous. And they noticed that patients that responded to resynchronization therapy were the ones that had most dysynchrony versus those that didn't have dysynchrony at baseline. So this study showed that the CURE parameter less than 0.7 was independently predictive of at least 15% increase in ejection fraction. And then they created this concept of a positive CMR profile, which included strain and scar, and showed that if there's no scar and there is a lot of dysynchrony, then these patients had a much higher, 12-fold higher survival rate. Now, you all know the literature on resynchronization therapy, And you know that large trials shows that there was basically no benefit, no improvement in outcomes if you select patients based on strain and the synchrony. So I dare to tell you, what do you think is missing in these trials? And what I believe is a nice thing to look at is the combined features of looking at strain, viability, and perfusion combined. So you can really understand what would be the best target for resynchronization therapy. I like to call those triple maps. And I've started some projects looking at the triple map with a PET MRI at UCSF. It was funded by that vendor, and it's just work in progress. But I want to share with you this concept, as we are getting a PET MRI pretty soon at University of Washington. Advancing that triple map approach, I dare to ask you, what if really it's the peripheral zone that should be the target for those resynchronization therapies? And with MRI, we can actually measure the amount of scar, but map very precisely the peripheral zone with standard methods. Okay, now let me show you other examples where strain can predict outcomes in cardiac disease. This is a study that looked at idiopathic dilated cardiomyopathy. And interestingly, they looked at patients with mid-wall fibrosis, which we all know that are the ones that have the worst outcomes, and compared with patients without mid-wall fibrosis. And the goal was to be able to detect mid-wall fibrosis without gadolinium. And look what they found, that left ventricular ejection fraction was pretty similar between the two groups of patients with dilated cardiomyopathy, but those that had scar had a much lower circumferential strain. So the circumferential strain was decreased, and that tells us that will be a surrogate for finding scar in dilated cardiomyopathy. Different studies, same type of disease, idiopathic dilated cardiomyopathy. In this study, they included 210 patients and followed them for about 3 years. They did what I told you. They went back and they did a retrospective cohort study and used feature tracking for CMR assessment that was done 5 years back. And they look at composite outcomes. I'm sorry, you have a dog barking. So they look at composite outcomes of cardiac death, heart transplant, and aborted shock. And notice how all components of strain here were able to predict the outcomes. Now, most interestingly, when they broke into levels of ejection fraction and the presence of scar, still longitudinal strain was the most predictive of all the strains, had independent prognostic characteristics for outcome. Example of a patient with right ventricular heart disease. So this is a study that looked at right ventricular cardiomyopathy and looked at the ability to discriminate patients with known disease, normals, and those with preclinical or genetic abnormalities, carriers for ARVC. And here in this graphic, it shows in white are the controls, in gray are the carriers of the gene, and in black are patients with frank ARVC. And you can see that what they did, they compared different vendors that can actually measure feature tracking and showed that independent of the vendor, it was possible to discriminate patients with disease from normals, not as well to differentiate preclinical from normals, but disease than normals. And this can be quite challenging to diagnose, as you know, in clinical practice. This was one study we did at UCSF, and we looked at patients with bicuspid aortic valve. We used feature tracking CMR to see if patients with bicuspid valve had different strain compared to controls. They had similar ejection fraction, all normal ejection fractions. And as you can see, patients with bicuspid aortic valve had decreased circumferential strain rate when compared to those to the controls. So perhaps another field where strain can detect early abnormalities in the myocardial. Another example, this is a study in which we looked at patients with pulmonary hypertension. and we measured myocardial regional strain. This is an example case from the paper, and you can see here with feature tracking, there was decreased circumferential strain or abnormal circumferential strain along the septum. And that was clearly depicted here, and controls versus patients for the septum and for the global abnormality. So different study that looked at sync for that same regional strain in pulmonary hypertension was able to detect areas of decreased strain, particularly at the junction points. So you might say, oh, that's a wonderful surrogate for the areas of late gadolinium enhancement we see characteristic of pulmonary hypertension. So strain in pulmonary hypertension. One area that has a lot of potential is the look for cardiotoxicity, particularly in patients with breast cancer. As you know, minimal variations in ejection fraction can really determine if the patient can continue with the chemotherapy or stop. And therefore, the need to detect early regional dysfunction probably will advance the field in patients with cancer cardiomyopathy. So this is an example of a patient that had no late gadolinium enhancement, but on tagged CMR showed areas of regional dysfunction. This is another example of a CMR sync in breast cancer cardiomyopathy. So this is a patient before and 2 cycles of chemotherapy after. And you can see this acquisition in the 4 chamber and 2 short axis plane. And you can see how there's much more yellows or areas of decreased strain after cycles of chemotherapy. And the ejection fraction had minimal change. So a very interesting area for CMR strain in the near future. Okay, now we are at our third focus today, which is building patient-specific models based on strain. So this is a model courtesy of Dr. Guccione's lab at UCSF. He's a bioengineer and he works in a multi-specialty lab to develop these models of the heart based on strain, on morphology, and on imputing several different features such as pressure and volume, and even tissue characteristics to predict how a heart is going to behave to a certain insult. And I've had the pleasure of doing some collaborative work with the group, and this was done in 2015 when we first did the human study in which we built a patient-specific model to predict remodeling. So the technique is called finite element model. So it's based on the geometry of the heart on MRI and on the strain features. Segmentation of the chambers is performed, and you generate this map, that is a mesh map of the left ventricle. And then you input the expected normal alignment of the fibers from a diffusion tension imaging model. This is not patient specific yet. This is just a standard alignment of the fibers. And based on the strain and the alignment of the fibers, you can then simulate how the heart is going to behave to different changes in the environment. This was a patient-specific model in which we were able to input, based on diffusion tension imaging, the alignment of the fibers of that particular patient. And then we simulated what would happen with that geometry and that alignment of fibers if you increase the volume. So we put volume overload, and you can see how we could predict that a specific area would dilate. And then when we remove that simulation of volume, you could see that most of the areas would return to normal volumes, but there will be residual dilatation at that particular area based on the alignment of the fibers. So this is modeling of growth, and we call it model of growth and reverse of the heart, or reverse growth. And you can input different you can input the increased volume, increased pressure. You can change the dimension of the fibers or the alignment of the fibers and see how that would affect the remodeling. Now, you can also go one step further and create what's called cardiac stress map. So you can use these finite element models, generate the same computational models, but then it's input the precise alignment of fibers of a particular patient. And when you have the fibers and the strain, you can calculate stress. So stress is force that causes deformation of the fibers. If you know the fiber alignment and the strain, it's possible to estimate stress. So this was a patient status post-Ross procedure, and we were able to create this color-coded map of stress in the different regions of the myocardium. Now, going along with this concept of generating patient-specific models and measuring cardiac work or cardiac stress, our team at UCSF used PET MRI to measure cardiac efficiency in a regional basis. So this is work from Dr. Gulber's lab. And what we did is basically we used a few normal volunteers and patients with disease that go into this PET MRI scanner that acquires simultaneously a PET and an MRI. And based on the MRI strain, we calculated myocardial work. Let me move this out of the way. So we calculated what's called myocardial external minute work, and that's a measure of work per region of the myocardium. And at the same time, we injected acetate and measured MVO2, which is a way of calculating oxygen consumption. And by looking at the amount of work per oxygen consumption, it's possible to measure cardiac efficiency in a regional manner. And we did that as a prototype at UCSF. Now let me finish by showing you some work that can be done by simulating interventions using the same concept of a patient-specific cardiac model. So this is a work from engineering, work from the bioengineers at the VA San Francisco, in which they created this patient-specific model simulating rupture of a papillary muscle. So they created the misalignment of the fibers in the left ventricle to simulate what would happen with the mitral valve if the papillary muscle was ruptured. And then after that, they generated a 3D map showing you the dysfunction of the mitral leaflet and used one prototype surgical material to suture back the mitral valve leaflets and document what would happen with the leaflets with that particular prototype. This is a very interesting paper, and then they used this specific prototype, but after that they used different types of devices to see what would be the most efficient to correct the mitral valve dysfunction. So that's all I had to share with you today. So I hope to leave with the message that CMR is a robust method for myocardial strain measurement, that the tools are evolving and more the post-processing is user-friendly and likely to have a role in clinical care. There's many potential clinical applications, particularly for early cardiac dysfunction, and particularly few that are promising for research are heart failure imaging and myocardial energetics, and building patient-specific models to guide interventions or guide different or simulate different treatment methods. This is the team from UCSF. This is, I had a collaborator already at UW, Dr. Alexander Veres from bioengineering, and collaborators from other institutions. And my goal is to grow the list of UW collaborators in the near future. Thank you very much.